We go on to the first speaker, and that is Dr. Tim Roberts, please.
Thank you. Well, welcome to our lunchtime session, and it's a pleasure to be able to share some of our experience which we've had with this lens going on to nearly 5 years. And I've worked with a lot of the companies and looked at all the different lenses, and my primary criteria is patient care. We as ophthalmologists are very fortunate that there are a lot of companies bringing extremely good products to market, and we can look at what's out there and choose what we believe is the best for our individual patient. And when we look, there's an increasing array of lenses that are now available, so it becomes a little bit tricky just exactly how we work out in our practice, how we're going to choose, what are we going to seek for an individual patient, and how we can get the best outcomes. So I'm in private practice in Sydney, which is where I do all my refractive cataract work, and then I have an academic appointment as professor at the University of Sydney, which is more teaching with monofocal lenses. And I've used all the monofocal and most of the extended depth of focus and trifocal lenses that are available. And over the last 5 years, we started using the Pure C as part of the proof of concept trial in 2020. And over the last 5 years, in my private practice, there's just been a steady growth. Over 40% now of patients are being implanted with an EDOF lens, about 5% with a trifocal, and then the others are monofocal, which we'll discuss a little bit later. Who are the patients who when you start, you probably might want to avoid a non-monofocal. So I think this is an exciting lens for those of us here in the room who might be just using monofocals, who haven't sort of thought there's a value out of the trifocal in your practice because of all the chair time and the perceived issues with dysphotopsia. So I think a discussion for competent comprehensive surgeons using monofocals, considering moving to an EDOF. So if we think what is the perfect extended depth of focus lens, well, essentially the key principle is that we maintain really good distance vision, and then it gives the progressive elongation of the focal point so that you can focus from distance through to about 1.5 diopters. So it's quite helpful at the beginning because EDOF started a little bit more as a sales and marketing term rather than a medical term. So when we were reviewing for journals, it's actually important to look technically what actually is an EDOF lens. So if we have a look, these are the definitions. First of all, you have to have statistical superiority in the mean distance corrected intermediate vision. The important thing there is distance corrected, because a lot of us as surgeons will do mini mono vision with a monofocal. So if you leave your patient minus 0.75 or a diopter, they're going to get good intermediate, but that's got nothing to do with the lens you put in their eye. So you have to distance correct them, and then the intermediate and near we get is what the optics of the lens are doing. You need at least 50% of patients that you're putting them in to have a distance corrected intermediate vision of 0.2 or 6.9 or better. You need to have proven that there's at least half a diopter of a greater range of vision than a monofocal lens. And equally as important for us clinically, we need to be absolutely certain that the quality of the distance vision is not going to be inferior to our monofocal lenses. And so those are the four definitions in terms of refractive results of what's accepted now as an extended depth of focus lens. So when we have a look at all these different lenses that are available, there's lots of different technologies that different companies are using. There's diffractive, refractive, there's small aperture, there's wavefront, there's chromatic aberration, there's spherical aberration. So there's a lot of different technologies that the optic physicists are using to try and generate this extended depth of focus. So what has the Technis lens done? What have they chosen to do? So this lens is a refractive design based on the Technis platform. And what happens is that in this case they've chosen the posterior surface for manufacturing reasons, but there's a change in the elevation on the posterior surface. It's gentle, there aren't discrete changes in elevation. It gives the elongated focus, and my hope would be, because of the design of the lens, it's going to minimise unwanted visual side effects. So the initial proof of concept study was designed to compare two refractive prototypes with an enhanced monofocal. The thought of the company was that if the lens isn't statistically superior to an enhanced monofocal, there's no point putting all the commercial money and time into marketing it. So they set the bar higher by comparing the Pure C prototype to an enhanced monofocal rather than a non-enhanced monofocal. And this was a randomised controlled double-masked study, multi-centred, of which we were one of the international investigators. So just top line, what did it show? Top left, when we put the Pure C lens in, it gives absolutely equivalent distance vision to the monofocal. So the first thing that we need to have confidence as a surgeon, distance vision, tick. If we look here in the middle top, there was a statistically significant improvement in the Pure C eyes compared to the monofocal eyes, so they had much better distance vision. And if we have a look down here, this is what a depth of focus curve, this is 0.2 or 6.9, and if you drop below it, your vision's dropping out. And you can see with the enhanced monofocal and the top lines, the Pure C, the patients were getting 0.7 diopters up to about 1.6 diopters of extended focus with the Pure C refractive lens. Another safety issue, if you will, what happens with contrast sensitivity. So we looked at low light conditions with glare and no glare, and as you can see in both of these box plots, there was no statistical difference between the quality of vision between the refractive EDOF and the monofocal. So distance vision's the same, tick. Quality of vision, contrast sensitivity is the same, tick. Improved distance vision, improved intermediate vision is better, significantly, tick. So then we had a look at the flip side is the patient's response coming back to us. And in terms of halo, starburst and glare, we can see two things. One is it was almost exactly the same as a monofocal. And the second thing is it was extremely high in terms of acceptability and low side effects. And then if we have a look down here in terms of satisfaction, again, when we're comparing for distance, exactly the same. And as we go to intermediate and near, a significant improvement in patients who were more satisfied with the quality of their vision. And this was all masked, so we didn't know what they were getting till we unmasked at 6 months. Significant improvement. And then in terms of recommendation to family and friends, which is actually a really good validated metric of an individual patient's perception of how they find the lens in their eye. Because if you ask them, how do you find it? Sometimes they don't know the words to say. It's very accurate. If you say, would you recommend this to a close friend or a loved one? It's a very good indicator of whether they're happy with what they've got. And you can see it's very, very high. So the proof of concept study was very significant, such that the company then decided to commercialise the refractive EDOF lens. And then in early 2024, it was made available in Australia with a toric version. Just as a comment, astigmatism or residual ametropia is the absolute commonest reason you don't get satisfactory results with an EDOF lens. So just the starting point for any patient is that we have to get spherical equivalent and astigmatism as tight under half a diopter as we can, otherwise the lens is going to fail. So however you treat astigmatism, please have that front of mind before you even consider using the lenses. So I put about 150 in, and these are the results of 50 bilaterally implanted patients with 6 weeks of follow-up. So if we have a look, good range of age, good range of flat to steep Ks, Ks of short eyes, long eyes, astigmatism. And you can see the mean spherical equivalent target on the Barrett is a little bit minus. This is just the current working point with the A constant from the company, where they're recommending that we choose the first minus till we individualise our A constants, because there's a slight shift to the right, which I'll show you a slide. And so that's why the target is slightly on the minus side. And then when you start, and what we did in the study was plano-plano, we get some more experience, these lenses do very, very well with sort of plano and -0.5 in the non-dominant eye. But that's why that's -0.3. So if we have a look at the refractive results, the arithmetic mean just means the plus and the minus outcome, so it gets very close to 0, but it gives you the standard deviation. The absolute mean does count in plus or minus, but we're seeing for a first up trial, even the very best studies we can get are about plus or minus 0.25. So these were very acceptable results for the initial data. So as we can see, the curve slightly shift to the right, up to 1/4 to 1/2 of a diopter, with a very acceptable number within 1/2 a diopter of the target. So what we then did with our research PhD scientist in our rooms who does all our research, we went back, we had a look at our mean arithmetic error. This is the A constant recommended by the company for the lens. What we did was, you may be aware of some of Gatinel's work, we back calculated using a theoretically reconstructed A constant. The trouble with Barrett and Gatinel, the black box, we don't know what's in it. So it's not a publicly disclosed formula, so you can't actually calculate it yourself. Some of the other formulae are publicly disclosed, so you can do the exact calculation. So unless you send all your data off to them, you have to do sort of back calculations. But when we did that back calculation, you can see with some individualisation of the A constant, the curve shifted right to the left with a very tight mean arithmetic error of almost 0. So, results, what do we get in the real world doing this? The green's the corrected distance vision before surgery. So these are cataract patients, these aren't refractive lens exchanges. And the blue here is the uncorrected distance vision. And, up to 60% are 6.6 and a good range of uncorrected distance vision. I then looked at, these lenses principally work bilaterally implanted. The human visual adaptation is that way. So 1 + 1 = 3, I tell all the patients. So I do try and bilaterally implant them. I've used a lot of Vivity, got very good results with it. And so when I compared the results, I'm very pleased, favourably pleased, that the percentage of uncorrected bilateral distance vision is very good. And the reported feedback from patients is very, very good that they've got crisp, clear distance vision, and we're not getting patients complaining of waxiness or problems with their vision. When we looked at bilateral post-op unaided near and at intermediate, again, as expected, the intermediate's very, very good. I would emphasise I do not tell patients this is a near reading lens. I talk about lifestyle for a computer, smartphone with the font up, but you don't want to set up expectations that they're going to be able to read small print, back of a pill bottle, lots of documents and things. If you've got a hardcore refractive patient who wants to read, if all else fails without glasses, they're going to need a trifocal. But N6 to N8 was very good. And then when we look, well, what does that actually mean in the real world? You can see here that it's really all of your average day-to-day activities that people were able to read with a good bright light. So good intermediate, and the added bonus was some near, but remember, it's not a near lens. And what we also found was that it was a tighter standard deviation, so there's more predictability compared to some of the other EDOF lenses I've used, that if you put it in across 100 patients, more of those patients are going to confidently have good lifestyle vision, spectacle independent. So what's the summary? Certainly when I compare a lens, the thing I do not want is lukewarm patients or even patients just not happy. But the feedback's been overwhelmingly positive about the quality of the vision and the lifestyle range. It's reliable and predictable compared to what you put into your algorithm, and your power calculation will be individualising A constants as we put more of these lenses in. You can do your routine biometry. If you know the Technis platform, it's exactly the same. So it's a very stress-free conversion. Minimal or no dysphotopsias, that's what I really like, that the feedback from patients is pretty much monofocal quality. So I'm a firm believer there's no free lunch. You've got to give up something, but the perceived drop in contrast sensitivity and light energy for distance certainly wasn't fed back. So I think it is going to be a game changer in my practice. I've got a higher degree of confidence now compared to other EDOFs that if I put this lens in, I would start with an otherwise healthy eye. As you get more confident and you see the results, I might find patient with mild glaucoma, not split fixation, who's had it for a while, hasn't progressed, I'll put them in. Very mild early epiretinal membranes or diabetes. But by and large, start with a healthy eye. It's my choice now, and I think for healthy eyes, I'll be up to about 50% of patients who'll be considered for a PUC. So thanks, that's our experience now over 5 years, and it's been a very positive time, and I really encourage you to have a look at this new lens. Thanks.